One of the things I like about being up here to speak is I don't have to worry about Warren holding up a sign that says I'm out of time. Hattie, in her opening comments, you may recall, mentioned that she had worked with one person for 20 years on related health issues. I think I may be that person. I just want to make it clear to all of you that Hattie and I started doing that in high school. So it was about 10 years ago that I got my first coronary artery calcification scan because I decided it was a good idea. I have a unique relationship with my physicians. I do not believe in shared decision-making. That's one of the new things. Everybody's saying shared decision-making. I think that's bunk. I make the decisions. My physician recommends. And if my physician doesn't recommend, I get a different physician. And they know that, so they recommend. So I said, I think maybe it'd be a good idea to get a coronary artery calcification scan. What do you think? He said, Warren, anything you say. And so I did. Now, what's amazing is I was totally asymptomatic, and by every indicia, lipids, hemoglobin A1C, blood pressure, I was well within normal range. A normal doctor would have thought this is irrational, but it was my decision. So come to find out, I got a report back, and it's not really how it should have been worded, but it said I'm in the top 25% risk for having a heart attack. So that got me to what I like to call the who's the guy the forerunner of Kaiser? Sidney Garfield. I like to call it the Sidney Garfield treatment plan, right? Baby aspirin, little lisinopril, 20 milligrams of simvastatin. Then my second scan, about 5 years later, showed that there was an increase in calcification, and there are reasons for that. Nobody knows exactly what, but by then atorvastatin was generic, and I switched to that. I think this process, this procedure has great potential. I think it has potential to save money because if people are at presumably high risk in the Framingham, but they don't have any calcification, why should they be taking statins? And I also think it's very important for folks like me who seem completely normal but have a family history. In my case, among the 4 grandparents, 2 heart attacks, 1 stroke, and my father CHF. That was enough of a history to make it sensible to me, for me to pay my money to get the scan. Now the cost of scans has gone down dramatically, and I think I'm going to shut up because I'm dying to hear what you all, as experts in the field, have to say about this incredibly important, timely topic, which is moving rapidly from folks thinking it's experimental to ultimately becoming standard of care. And if we can hasten that process along by listening to you, that's what I want to do. Thank you very much. Now, I want to introduce you all very briefly because nobody's read the manifest. I'll do it for you. David Maron is the panel chair. Raise your hand so people know who you are. David Marin. Okay. Arthur Gaggetston, Daniel Berman, Matthew Rudolph, Marianne Champagne, Michael McConnell. This is a good one. Moretza Nahavi. Did I get that kind of close to right? Sorry, sir. And Ian Rogers. Thank you all.
Thank you very much, and good morning. I'm David Marin, and I'm here because Hattie told me to be here. I think it's a great opportunity to make a difference in the state of California regarding the use of this particular technology, and to be able to present to you the evidence, to you agents of change in the state, to try to make a difference in the health of the people that live in California. When Hattie asked me if I could assemble a group, I just called the people that are really expert because, frankly, I'm not the leading expert in coronary artery calcification. So I was fortunate to be able to recruit a fantastic panel, and after a case presentation that I'll make to you, and you'll use your audience response systems, a brief video from Ireland, Dr. Matt Budoff, one of the world's experts in coronary calcium scanning, will review the evidence with you. I'll come back and show you what we propose should be the practice based on guidelines that already exist, and then have a panel Q&A. So, a case. 55-year-old asymptomatic white man presents to me asking, should I be on a statin? He has high cholesterol. Let's see, I don't know how to use this yet. Looking for the laser. Top red button. Okay. So his LDL is high, 156. And he's got a family history. His father's still alive, but his father had an MI, first MI at age 50. He's an athletic man who is a butcher. Being a butcher may be a risk factor. It's not a conventional risk factor. And so, question, what would you do? Would you prescribe a statin with that history and risk factor profile? Would you not prescribe a statin or aspirin, just leave things alone, an asymptomatic middle-aged man, intensify lifestyle, or calculate a risk score? Please hit your buttons, and that's not a very complicated or challenging question, and I guess I hit forward to see that about half of you would prescribe a statin and aspirin, and half of you would calculate a risk score. So what I did was calculate a risk score. Because, you know, what we see in clinic a lot, and maybe it's because in the preventive cardiology clinic we're seeing a special population, a lot of people are very reluctant to take a statin. So we calculated a score. So with that history, what do you think his score was? 3.3, 6.6, 9.9, or 13.2%? Okay, another, yes, Mike.
You just want to describe more broadly what the ASCVD stands for and what it's a risk of.
What is ASCVD? What is the ASCVD risk score? ASCVD is for atherosclerotic cardiovascular disease, and basically it's heart attack and stroke. And it's something that is now in the cholesterol guidelines that we're supposed to be using from the American College of Cardiology, American Heart Association, based on age, race, sex, blood pressure, the systolic blood pressure, the total cholesterol, HDL, is the patient hypertensive on drug therapy, does the patient have diabetes, does the patient smoke, and plug in those numbers. It takes a few seconds on the smartphone app, and you get a number. If your number is 7.5% risk over the next 10 years of having an atherosclerotic cardiovascular event, then the patient falls into a category where a statin should be prescribed, but it always requires a conversation with the patient. Thanks, Mike. So you've had enough time. Let's see what your responses were. And about a third of you thought it was 6.6, third thought 9.9, and third 13.2. The answer was that this man had a 6.6% risk, which is short of the 7.5% threshold for prescribing a statin. The 5% to 7.5% threshold, we are told in our guidelines, should be a discussion and consider statin therapy depending on patient preference and maybe the presence of other risk that is not in those very basic risk factors I listed for you. So what would you do now with a 6.6? I guess the question became A, so don't do A. Prescribe a statin and aspirin, don't prescribe a statin and aspirin, intensify lifestyle management, or order a coronary calcium scan. Gee, I wonder where I'm going with this. Okay, so let's just go and see how you responded. Okay, intensify lifestyle management, a very reasonable response. A third of you said order a calcium scan, and guess what I did? So this was this man's coronary calcium scan. The bright white reflects calcium. Calcium does not belong in coronary arteries. When we're born, we don't have calcium. Calcium becomes incorporated into atherosclerotic plaque as it matures, becomes more complicated. And so this is a high calcium score. I'll save any further comments about that to Dr. Budoff. So now you've got this calcium score, and I'm trying to go to the next slide. There we go. What would you do now? Prescribe the aspirin and statin? No. Order a stress test or refer for cardiac catheterization. This is a high, high score. So please use your audience response system. It's not counting. There we go. Okay. And yes. So, oh no, it's still tabulating. But for the sake of time, let's see what the next response was. So, of respondents, about half would just prescribe the aspirin and statin, and a half. That's a high. Wow. It's a pretty aggressive group. Would order a cardiac catheterization, presumably to define the anatomy in this asymptomatic person. If I had time, I would tell you about the COURAGE trial, but we're going to have to save that for another time.
Take just one moment to say what the conclusion of that.
The COURAGE trial, we took people with coronary artery disease who were stable. Cardiac catheterization showed that there was at least one artery with at least 70% narrowing. And then we randomly assigned them to get a stent and be placed on good medical therapy or good medical therapy alone. And after about 4.5 years of follow-up, there was no difference in heart attack and death between the groups. In other words, adding a stent to optimal medical therapy did not reduce the risk of death or heart attack. That's the COURAGE trial. And people who are asymptomatic really cannot benefit in terms of quality of life from getting a stent. So why you do the cardiac catheterization, again, it's a different discussion, but not done by me with this patient. I started an aspirin and statin. So I don't know if I need some help clicking on the link, and this is from the Irish Heart Disease Awareness Organization.
So as this starts, just say what the right answer was. It was A, right?
Well, what I did was start aspirin and statin and intensify lifestyle management at the same time. And I would say, in my humble way, that was the right thing to do.
The Widowmaker is a film that exposes and explains, perhaps for the first time, a heart disease industry that profits from fatal and expensive intervention over accurate and life-saving prevention. It is a truly shocking story. But an Irish charity aims to change the ending of that story. Irish Heart Disease Awareness plans to transform thinking in relation to heart attacks. Supporting this call for change are hard facts and sound science, built up over a quarter of a century. Most cardiovascular disease could be detected much, much earlier with a simple, non-invasive and once-off calcification test. The test produces a score running from 0 into the thousands, and that score correlates with the amount of heart disease in your arteries. And when it's discovered, heart disease can be treated and managed, just like we do with any other disease. But cardiovascular disease isn't just any other disease. It is the world's biggest killer, claiming more lives than all cancers combined and the lives of 7 times more women than breast cancer.
This situation has come about despite decades of verified, peer-reviewed findings from studies of tens of thousands of patients.
Most heart attacks are not random events or bolts from the blue. They are not inevitable. Oncologists use mammograms to seek out and identify breast cancers, and women would settle for nothing less. They certainly wouldn't settle for being asked just 5 questions to estimate their percentage chance of having breast cancer. And yet, this is the approach taken when it comes to the heart.
In cardiology, it seems it has to be a crisis before it's a problem.
What we want to give you in this short film is a flavor of the overwhelming evidence that coronary artery calcium scoring tells you whether or not you have heart disease, because the calcification it detects only arises in diseased vessels. The hardest fact of all isn't disputed. There's a proven and powerful correlation between the presence of calcium in your arteries and your likelihood of a heart attack, which in a third of cases results in death. But the good news is that heart disease is detectable, measurable, and manageable, and lives, instead of being lost, can be saved.
In 2007, a study published by the American College of Cardiology Foundation tracked the outcomes of more than 25,000 asymptomatic patients who were referred for coronary artery calcium testing. After 12 years, 99.4% of those patients who registered a nil calcification score were still alive. However, for those with high coronary artery calcium scores, over 1,000, the outcomes were dramatically different. Only 76.9% of these patients had survived.
Between these two extremes were many patients who registered scores that were not yet dangerously high, but they now knew that their level of disease would need to be managed. The higher the calcium score, the higher the risk.
In another study, over 44,000 asymptomatic patients were referred for coronary artery calcium testing and their mortality rates assessed. 45% of these registered a nil score, and 99.5% of them were still alive at the end of the study.
So, research has established that the absence of calcification is good news for patients. But what about those people that do register high calcium scores?
Well, in 2009, a review of 13 major studies was published covering over 85,000 patients. Its figures revealed that patients with calcification are 8 times more likely to have a cardiac event than those without. This echoed a study published in 2000 by the American Heart Association, which discovered that 70% of all cardiac events happened in the top 25 percentile of calcium scores in each age group.
Many preventive cardiologists argue for a mindset shift when it comes to heart disease. Their passion is not based on gut, nor a hunch, nor intuition. It is based on evidence.
In fact, an expert review on coronary calcium in 2008 concluded that overall, coronary artery calcium is a better predictor of events than all the other risk factors combined, since it measures actual disease.
The review confirms that traditional Framingham score risk assessment still fails to identify many asymptomatic patients, until it's too late.
The American Heart Journal published a study of over 136,000 people presenting at 451 hospitals after heart attacks. The study revealed that half of them had normal LDL cholesterol.
And even for those that are identified, exercise stress tests or angiograms in asymptomatic patients may miss many of the most vulnerable cases because the artery blockages that the tests seek are not the cause of the majority of heart attacks or sudden deaths. 70% of heart attacks are instead caused by the sudden rupture of soft plaque. That's why so many asymptomatic patients go straight from just fine to dead. The real value of the calcification test is that it allows us to accurately detect whether or not there's actual disease in individual patients. Patients that might otherwise be inappropriately classified as middle risk by the Framingham population approach. And middle risk is where most heart attacks occur. People with high coronary artery calcium scores are immediately reclassified as high-risk patients. They learn that they have a time bomb ticking in their chest. It is natural, as we all get older, that our calcification score will grow. After all, heart disease is progressive. What is cause for particular concern is when your calcification score grows in excess of the average for your age. That's what the test tells you, that there's disease in your arteries.
A 2006 study in the European Heart Journal demonstrated particularly effectively the predictive power for the individual of calcification testing versus other methods of population risk assessment. It studied over 10,000 asymptomatic patients and found that smoking doubled the risk of death due to heart attack. No surprises there. But the study also revealed that a non-smoker with a coronary artery calcium score in excess of 1,000 was 7 times more likely to die than a smoker with a score of 0. More than 20 major studies over 25 years have all added to the momentum behind calcium scanning as a strong predictor of future cardiac events. Together, they have accumulated irrefutable evidence that a high calcium score is bad news.
It sounds almost too good to be true. So why would someone argue against the widespread adoption of calcium scores and persist with the old system? The critics will tell you that the scan involves radiation. It does, about the same amount as a flight to New York. The skeptics will also point to cost. A scan is expensive at €250. The IHDA asks if you'd readily spend €250 to know if your car might suddenly crash and kill you. Or would you rather pay €30,000 to €50,000 for a bypass or stent? That is, if you're lucky enough to survive a heart attack long enough to have the surgery. Critics will say that coronary artery calcium screening does not pinpoint vulnerable plaques. No, but it does identify the vulnerable patients. Like an iceberg, if you have calcified plaque above, you have dangerous soft plaque below. And knowing that would empower people to take control of their own health destiny. Finally, the skeptics will contend that it has never been proven that knowing your calcification score will change anything, that people won't act even if they learn that they have heart disease. Well, 2 major randomized studies demolish that line of argument.
The Eisner trial, published in 2011, demonstrates how undergoing a calcium scan can be a powerful motivator. Those patients that learn their score, who are told that they have a disease and who are shown a picture of its impacts on their arteries, do take action. And what is seen is an association with superior risk factor control. Meanwhile, an analysis in the following year of the St. Francis Heart Study showed the benefits of medical therapy for those at high risk. In a double-blind, placebo-controlled trial, the journeys of over 1,000 patients were analysed. And significantly better outcomes were noted for those classified as high risk when a preventive approach, including statin medication, was adopted.
It's common sense. As with any disease, the sooner you know, the more you can do. Preventive cardiologist Harvey Hecht has referred to what he calls a deadly double standard, whereby the 65-year-old default system of risk assessment in cardiology known as Framingham has never been subjected to randomized controlled trials such as Eisner and St. Francis.
The findings of the COURAGE trial, outlined in the most recent European guidelines, represent yet another landmark in the journey of acceptance. It compared patients who received a stent and medical therapy with those that embraced medical therapy alone. The trial showed that conservative management was more effective than aggressive interventionist approaches.
In fact, the 2013 European guidelines recommended that medical therapy should be the default strategy in stable heart patients once a stress test had been passed.
We've been inferior doctors in cardiology for quite a long time. We've been waiting for heart attacks, we've been waiting for chest pain, we've been waiting for patients literally to suffer sudden death to jump in there with guns blazing and catheters interacting and trying to save them rather than getting to them earlier before the first event. I think we're really falling short on our oaths to improve heart disease care.
Slowly, it seems the message is getting through. The American Heart Association guidelines now recommend that coronary artery calcium testing should be considered for asymptomatic adults at intermediate risk. And that position is echoed by the official guidelines of the European Society of Cardiology.
But it has taken 25 years to reach this point, and most doctors in the US and Europe remain unaware of the test and unaware of the endorsement it receives in the official guidelines.
The world continues to accept the scourge of cardiovascular death like an inevitable event, a deadly lottery. For 1/3 of its victims, their first symptoms are their last. Many ate well, didn't smoke, didn't drink to excess, and watched their weight. All great things to do, but as individuals, they did not know they had heart disease. But the hard facts about heart attacks show that you can, anyone can, dramatically improve the odds. Now that's what I call a happy ending.
Okay, we all like watching a movie. Here he is in the flesh, Dr. Matthew Budoff, to review the evidence behind coronary calcium scanning. Matt is professor of medicine at Harbor UCLA.
Thank you, David and Hattie, for putting this panel together. It's my pleasure to be here and share with you some of the evidence that dates back to Dr. Agustin's earliest work on this, going back to 1989, so now actually over 25 years of research. So we already heard that the first event is often fatal. This is not new news. This was published 20 years ago, that the first sign or symptom that men get are either a heart attack or death. They don't get chest pain. They don't get a little shortness of breath. They don't have difficulty getting up a flight of stairs. They just, unfortunately, have a major event. And women, it was about 50-50, but far too often. And as we just heard, we can't wait for the symptoms or signs to show up. We need to be a little more proactive. Now, the data with cholesterol therapy, as Dr. Damari already showed, was dramatic. The benefits have been seen. And I'll point out the National Cholesterol Education Panel was an educational program that tried to get the word out that cholesterol is bad and we have good therapies. And that also worked. Similar to what we saw with the university best practices to reduce events. But you see the effect. It was much greater in men than in women. In women started out with less heart attacks per year than men, and now exceed men in heart attacks, and in strokes, and in heart failure, and in cardiac death. The heart disease is actually a female predominant disease now. It's totally shifted. And the primary reason is two problems. One, that as physicians, we emphasize male gender as being a major risk factor and thus maybe downplay the importance in women. But also, women, when asked what their number one risk factor is and number one risk is of dying, always universally answer breast cancer, when, as we heard, they're 7 times more likely to die of heart disease. So it's a population-based that we need to get to. This is 2011 data. You can see males, heart disease, women. Women are still leading the number of deaths from cardiovascular disease. This is all cancers combined. You can see that while heart disease has been going down, we're still far above all cancers combined. This is not just breast cancer or lung cancer or colon cancer or skin cancer. Pulling them all together, we still lose more patients every year to heart disease. We can see things like accidents, COPD, diabetes, Alzheimer's, HIV is way down off the list, all very small relative contributors to the overall problem. When we talk about women and breast cancer, we have to put things in perspective. When we're dealing with premenopausal women, breast cancer does kill more women than heart disease. But as they hit menopause and as atherosclerosis progresses, it becomes a 10-fold, 20-fold, 100-fold cause of death as women get older. So the relative importance goes up as age goes up as well. We heard about the traditional risk factors, the question posed in the Widowmaker. That wasn't the movie. That was a promo for the movie. The Widowmaker is on Netflix and Google Play as a full-length video. It was made independently. I had nothing to do with they just interviewed me for the movie, but it does go through. It's about a 90-minute movie that may be worth watching if you're interested in seeing more about the test. It also talks about stenting and the parallel experience with stents. But family history of premature heart disease, diabetes, high cholesterol, tobacco use, high blood pressure, and obesity and physical activity do contribute to heart disease, but combined, they only tell us about 60% of the story. So we look at these factors, no matter what risk calculator we use, Framingham, the new ASCVD risk that Dr. Marin described, or others, knowing the answer to these 5 questions answers 60% of the answer, and that's just not good enough. That means we're missing, by definition, 40% of people who don't have these risk factors or don't have significant risk factors but end up having cardiovascular events. Can the calcium score help us? Can finding these little plaques, and as it was mentioned, the radiation dose is about the same as a mammogram. So if we're going to advocate from a screening perspective that mammography is good for breast cancer, then I would say something that kills 7 times as many women would be worth the same dose of radiation and about the same cost. But it doesn't just tell us how much heart disease you have or how much risk you have at that moment. It literally tells us what the lifetime accumulation of atherosclerosis is. At the bottom of Dr. DeMaria's slide, when he had 20 different risk factors, at the bottom it just said atherosclerosis is the best predictor. And that's true. Having the disease is the best predictor of suffering later from the disease. There's no way to argue against that simple premise. It overcomes the limitations of population-based assessments, the idea that I have normal cholesterol, therefore I can't have heart disease. Cholesterol is just one of many risk factors. So you can have normal cholesterol and have terrible heart disease. We can't look at an individual risk factor and know what's going on in your own arteries. So it adds value to what we know about risk factors. It helps fill in that 40% gap that we get from asking 5 simple questions. So what we see about half the time, and it's important to understand, we call this the power of 0. When you have no coronary calcium, you have a 10-year and recently published a 15-year event-free survival of 99%. That's a very good insurance policy, that your chance of suffering a heart attack or stroke goes to almost 0%. So it's like golf, low score wins. We don't want to have a lot of plaque, and as we saw from our example this morning from Dr. Marin's patient, severe calcification imparts a very high risk. The risk of a score over 1,000 in our paper was over 50-fold, 50 times more likely to die after controlling for risk factors. You are 50 times more likely to die if your score was over 1,000 than if it was 0, all other things being equal. And these are asymptomatic people. So it's a big deal when we think about it in perspectives. Now, how does the coronary calcium score compare to all the other cardiac tests that we can order for our patients? We are not supposed to take asymptomatic people and order functional testing, treadmill tests, nuclear tests, stress echo. And the simple reason is they're looking for the wrong disease. They're looking for the patients who have a 70% blockage or a 90% blockage, and that's bad. But that's not the plaques that